Welcome, everyone, to the Kidney Korner Podcast. I'm your host, Craig, also director of Get in Position Foundation, and I'm also a kidney health coach with the American Kidney Fund. Welcome this evening to our awesome episode where we will ask a nephrologist, actually, ask Dr. Kumar. we will be talking about kidney disease and preventative care tonight. Please, as always, I ask that you would share this link to anyone you may know dealing with kidney disease who may be currently on dialysis. Many of you may know my story. I dealt with CKD for over 23 years. I was on dialysis for 4 years to be exact. And in November of 2023, I received my kidney transplant. So I'm also a kidney transplant recipient. And could you believe it's coming up on 1 year next month? Wow, God is awesome. He is great. And I am happy to be here with you. So again, share this link. Come on in to the Kidney Korner Podcast. We got a really great episode this evening. I'm excited about it. But before I bring in our very, very special guest, who I am so stoked and excited about, there's a couple of things that's going on. This month. For those individuals who are on dialysis this month, and you have Medicare, it is open enrollment. It is an open enrollment season right now. It started October 15th. It's going through December 7th. So make sure you take a look at those things. And if anyone is on the kidney transplant list, this information is for those individuals who's on the transplant list, those individuals who are getting evaluated, seeking to get listed. It was described to me this way: if you're satisfied with what you currently have on Medicare, with Medicare, you don't need to make any changes. Listen, if it ain't broke, don't fix it. Okay? Don't try to fix it, because one of the processes with getting evaluated, you will speak with social workers. And the social workers, their job is to see, okay, how is this all going to be paid for? Is your insurances in place? We don't need no interruptions, okay? Because we need for you to get that transplant or to get on that list, okay? Why? Your life depends upon it, all right? Your life depends upon it. We don't need no issues. We don't need no delays or interruptions, okay? So if it ain't broke, don't try to fix it. Just let it keep going. Let it roll over, and you'll be fine. Okay, so if you are on dialysis and there's some other things that you need, only change it if there's some extra things that you definitely need, as far as maybe extra prescription coverage or vision, dental, something like that. If you absolutely need it, but if you don't, just let it roll on. Okay, so that's that. With that. Also, October is designated as Health Literacy Month. This right here is where we celebrate a time to recognize the importance of making health information easy to understand, and also the healthcare system easier to navigate. I mean, how many of us have an issue, make a call or trying to get to the right person? So this month is Health Literacy Month, and it's a great segue to get into or bring our guest on. And so what I want to do is actually, if you all out there listening, viewing, and watching live know anything about my story and what we did, we actually did a docu-series. It's on this YouTube channel, so share the link. I did a docu-series entitled From Diagnosis to Transplant. So I'm sharing and telling my testimony, my story from the time I was diagnosed. That's episode 1, actually. But episode 2, very interesting. Very interesting. It's entitled Finding Dr. Kumar. And the funny part is that it's not our nephrologist, our special guest tonight, but he has a lot to do with it, right? The name, he has a lot to do with that. So if you haven't seen that episode, you can see it here on our YouTube channel at getinposition21.org. So make sure you check this out because it has a lot to do with our very special guest. So without further ado, because we got a lot to cover tonight, I'm telling you, we got a lot to cover tonight. I forget do I forget the year? No, the year was 2019. Yeah, 2019. He became my nephrologist. Took very great care of me. I'm excited about tonight. So let's give a warm Kidney Korner welcome to Dr. Srikar Kumar. Dr. Kumar.
Hello.
How are you? Welcome to the Kidney Korner. Yeah.
Well,
Let's clap some applause.
Yeah, so let me first say it's an honor to be here. I've, like I was telling you, earlier, I've never been on a podcast, so this is my first time. I'm very excited. I'm glad to be here. Glad to answer any questions and and just have a good discussion. I mean, to be honest, that's all I would like to do. Raise awareness about kidney disease and what else. There's a lot of exciting stuff out there, and I'm happy to share that as much as I can because I'm not a research expert necessarily. I'm in clinical practice, but I see a lot of folks such as yourself and folk before and after and everything in between. So I'm happy to be here, and so we'll be looking forward to a fun time.
Yes, indeed. So am I, and we're so happy to have you. And you have just become a member of the Kidney Korner, so you can come and hang out on the corner at any time. Let your hair down and just hang out with us on the corner at any time. So welcome. Before I introduced you, I mentioned that about my my docu-series. And actually, this docu-series, this particular episode, Finding Dr. Kumar, and I also mentioned that it wasn't based around you per se. You're involved in it.
I absolutely understand, yeah.
But to our viewers out there, it was, I believe it was 2004 or maybe 5. I believe it was 4 because me and my family, we were just relocated here to Atlanta. Stockbridge is the area, and you are a nephrologist with the Southern Crescent Nephrology team here in Stockbridge, Georgia. And it was really based upon your mom.
Yep.
Who was my original nephrologist, Dr. Kumar. She was my nephrologist, and I'm not sure. I don't know if you remember, but I believe you were in your last year of medical school, and you stopped by the office, and she was so stoked that you were there, and I actually had an appointment that day, and she introduced me to you.
Right.
And wow, she was she was so proud, and it made me proud.
It's crazy you say that. So certainly there were times even younger when I was in middle school, high school, I would stop by the office, but certainly medical school, I'd just kind of be hanging around, stop by. And I don't, at that point, when I saw you, I met you, I don't know if I knew I would be here these years later.
Wow.
In my mind, just to go back, of course, maybe it was in my blood, but, seeing my mom, what she loved to do, which was take care of patients, and specifically with kidney disease. And, it's hard not to get, like feel like you have to do that as well, when someone has that kind of passion. So through after medical school or residency, and surely enough, after a year or so, I decided, I'm gonna do nephrology as well. So when I saw you, I was still, I don't know what I'll do with my life, but
wow, that's interesting. That's really interesting, because that was really, as we get into it, we delve into this thing. That was actually a great segue into my very first question for you, Dr. Kumar, was, what made you actually choose that specialty? Because nephrology is a specialty, and I'm pretty sure you could have went, either way.
That's an excellent question. So one I love to answer. So way I look at it, they're sort of two parts. One part is just the medicine part of it. Nephrology, not to bore anybody here, but there are a lot of numbers, labs involved. So, growing up, I was always a math kid. I left my numbers and chemistry. At its core, nephrology does have a lot of that. Again, on the day-to-day, don't really use it much now, but if I really want to get into it, there's acid-base chemistry and electrolyte physiology and all sorts of good stuff. And I love to do that. So that was just the first part, just enjoying that part of it. But the second part is, the patient, the patients, we see patients everywhere. When I say everywhere, starts off in the outpatient clinic. In our office, we see patients from, usually it's chronic kidney disease, from anywhere from real mild changes in the numbers to more advanced, possibly needing dialysis and transplant down the line. Like I said, anything in the middle. So there's a lot of room to work with. We have a lot of new therapies and coaching and all sorts of things we can do now if that's chronic kidney disease. But also we have other electrolyte disorders. We see transplant patients in the office, kidney stones. You name it. I tell folks we're kind of like primary care doctors, but yes, we try to focus on the kidneys, everything going on. So, the point is, yes, we see folks in the outpatient setting. We see folks in the hospital, and everywhere in the hospital, both from the ICU to the normal floors. If technically, there are cases, pediatric cases and oncology cases. There's in the women's hospital. So, we're part of every part of the hospital, in the office, and of course, outpatient dialysis as well. And I think that keeps it, we see folks everywhere, and it keeps me interested, just being in a different place every day, keeps my mind fresh. But yes, we feel, I personally, I think we're taking care of folks, it's all over the place. And I think that's the most rewarding thing, is when we see someone, maybe they got sick, they're in the hospital, we see them as an outpatient, they get better, they're on dialysis, they get a transplant, they're doing better. And those are the most fulfilling things about my field.
That's amazing, because there was a period, I came in on a stage 3 chronic kidney disease, and one of the things I'll say first, and I always attribute my care, of course, to your mom. Of course, I had to do my part as a patient, but we were able to sustain my stage 3 for 18 years.
Right.
For 18 years. And it was, to your point, it was like, you all became my PCPs, and that's who I saw all the time. Like every 3 months, it was at your office. at the office, the Stockbridge location. I think I saw my PCP probably maybe twice a year because I was always in your office. And one of the things, it's a great segue to my next question was, what are some top or common things that you notice when you get to see new patients, right? Coming to see you. What is the most common, I guess, form of CKD? Because there are different types of kidney disease, right? As we know it. And so what's the most common type that you see?
Sure. So to that point, I mean, there are a number of causes of chronic kidney disease, and the reality is none of our kidneys are perfect, right? And I say this to everybody, technically just looking at the staging itself, stage 1, stage 2, stage 3, stage 4, stage 5, effectively stage 1 and stage 2, most cases are considered normal. And I put that in quotation marks. But in the end, no matter who I'm seeing, and whether you're a mild numbers or advanced, it's about looking at the risk factors for kidney disease. And, like I say, it's probably not just one thing, but it could be multiple things. And there's usually not one cause. So the most common is diabetes, diabetic kidney disease, diabetic nephropathy. There are several different names for it. So that's certainly very common in our country. And the reality is it's probably rising in incidence, and whether we have the numbers or we know about it, and it's a silent disease, and both the diabetes part of it, but also the kidney disease part of it as well. And I'd say a close number 2, and a lot of them, like a lot of the folks I see, have both of these, is blood pressure. So high blood pressure certainly is a hypertensive nephropathy, hypertensive arteriosclerosis, whatever you want to call it. These are all within the subgroup of common causes of chronic kidney disease. So most of the folks I see have some form of diabetes, high blood pressure, and just that goes along with what we call as metabolic disease. So certainly obesity, weight control is very important for kidney health. And your heart health. And a lot of the medicines and things that are out there, you may see commercials, and we'll probably end up talking about some of them here, that are for the kidneys are actually heart medications. And what I tell folks, heart and kidneys are like best friends. So, in the middle of this, you have diabetes, you have blood pressure, and, if one gets upset, the other one's going to get upset too. And that's where we see a lot of folks, especially in the hospital, the numbers are going up and down, the kidney numbers, I should say, are going up and down. And so that's where a lot of folks we see have to have good diabetes control, good blood pressure control, just regular good old primary care, standard of care, and then a lot of them may need cardiologist or something like that to kind of keep an eye on their heart function and all that. So that's the most common things that we see. Just to finalize a couple of things here, there are a lot of other causes of kidney disease as well. Urologic health certainly is important. So kidney stones, any abnormalities in the kidneys and the bladder, that can certainly act up the kidney function part of it. So you can have, I have folks that they're born with one kidney, and not a big deal. And we find that out at 70, 80 years old. But those type of things we always want to be monitoring for. But certainly if there are, any other type of urologic abnormalities, so as you get older, prostate issues, bladder issues, those can be very important. And of course, and I'm not even hitting the tip of the iceberg here, but less common things. So autoimmune conditions, so lupus, sickle cell disease, basically anything that can, anything that can attack your body, your own antibodies that should be fighting infection. They may attack your skin, joints. They can also attack the kidneys. And we do see a fair number of those. And we always want to be making sure we're not forgetting about those other causes, just because diabetes and blood pressure is so common that we don't want to forget that all these other things can also exist.
And the other thing, because you mentioned early on in your answer, was in America we see most common than ever the diabetes, but also too the obesity. the obesity here in America.
Right.
So we definitely need to, because I understand that diabetes is the number one cause of kidney failure. Number two is hypertension, high blood pressure, and being obese, overweight is a cause as well. We could say that, and that could be attributed to the diabetes and the high blood pressure. So
right. Exactly. So when we say, for me, and this is my personal sense here, which is, I don't think of it as causes. I think of it as risk factors. Like, hey, what are the risk factors you have that could be causing or could be contributing to any type of kidney problems? And as I said, it doesn't matter where you are on this scale, even if it's minor kidney problems, but these are the risk factors we want to be looking into. And I say, it's not just me. Every health professional that you see should be saying the same things. All right, you do have diabetes. Let's keep that under check. Blood pressure, keep under check. Is there, along with that, and how do we do that? Right, it's common, not just medications, but it comes back down to lifestyle, eating healthy, exercise, and people always ask, well, what are the right things to do? What are the right things or wrong things? And I mean, you'll see 100 different things on the internet. To me, we just want to keep it simple, right? So fruits, vegetables, lean proteins. You're trying to avoid the stuff we know we shouldn't be eating, the fast foods, the processed foods, things that are chock full of salt, sugars. Trying to cook just at home is really the best. And if you have diabetes, you're trying to keep the sugars under better control. If you have blood pressure, salts under better control. And not just stuff we're adding in, but just everything we eat is already pretty much processed with all of that. So that's why I say those are where we want to start. And exercise, like I say, there's no right or wrong. If you can just go outside, walk outside for a few minutes, great. Don't need to be running marathons or anything like that. But
right.
These are the the basic parts we talk about every time I see a patient in the office. We're revisiting that is, hey, what are your risk factors? Not person down the street or in person in the next room. What is it? You don't have diabetes, but you do have blood pressure. You actually don't have both, but you have some heart problems or urologic problems. What are your risk factors that we want to be keeping an eye out on? And I always tell my job is easy. I just look at your numbers and say, hey, your things are stable. They're a little better. They're a little worse. But it's, it really is not that simple in the end of it, as I'm sure you know. Yeah.
Right. I'm glad you worded it that way. Risk factors. Mm-hmm. And I mean, we're just rolling right along because we're really gonna take the gloves off tonight.
Yeah. Come at me. No.
We're really gonna take the gloves off tonight because you are really hitting on some key factors. And from your tenure and seeing these patients, it could sound like, to you, does it sound like you're sounding like a broken record, like having to say the same thing over and over? Because we hear that a lot. Diet, exercise, diet, exercise, your lifestyle, diet, exercise. Do you think, from your personal opinion and experiences, is it a lack of education of what's going on, or do you believe, are people just doing whatever they want to do?
So that's a loaded question. So we'll take it one step at a time. So first off, I personally, I feel every patient is different, right? We have to look at, like I said, going back to that, we look at their risk factors and try to personalize it for them. And problems, of course, everyone I see says, oh, I'm eating healthy and I'm doing what I got to do. And there is a big part of me, I do feel, is there are some factors that are out of our control. And I don't know if it's, this goes back to, there's a lot of stuff out there about epigenetics and all sorts of things. I didn't talk about this previously, but I think family history is super important as well. Environmental factors are really important. So when I say environmental factors, I mean, there are folks living in certain areas that are more prone to this, more prone to kidney disease. We don't, like I said, we don't always know. There was my wife had showed me this article in the New York Times. It was pretty interesting. It was, I think, a couple of months ago about Sri Lankan, I think, fishermen. So different part of the world, younger patients, younger folks, younger men, and all of a sudden they were starting to have kidney problems, and they're thinking, hey, this is probably because they're out in the sea. There's a lot of pollution and things that's popping up now.
Right.
And they are starting to have things that are going on with the kidneys in particular that maybe we weren't seeing previously. So yes, yeah. Is it a broken record? I would make the.
Uh-oh. Kind of went out. Uh-oh. We got to get him back. He was saying something.
Oh, there we are.
Yeah, there you go. There you go. You were finishing up the thought of sounding like a broken record.
Right. So I would never say that it's a broken record. I think revisiting this, and like I said, of course, we want to try doing our best to avoid all the stuff I talked about. I mean, and we all like in moderation is always going to be okay, but we know that processed foods and all this stuff, we want to try and avoid it. And I think that's just a part of our lifestyle. It's just a part of our society that, it's hard to give up. But can we do better? The answer is yes. But that does not mean for me personally that, I think there are other factors out there that we always forget about. And I talk about family history, but I think it's very important. I think we don't always realize, how important family and genetics and all that is, and that sometimes no matter what we do, we may have problems down the line.
Gotcha. And I just want to say, for those who are viewing, if something sparks something in you with a question, write it down or just type it in the chat. If you're on either Facebook or the YouTube channel, just type your question down. We have a session or a section of the podcast where we will take questions for the good doctor. So just keep that in mind. If something sparks in your mind for the viewers, just put it in the chat, in the comment section, and we will get to you. So I wanted to ask you this question. What is the ratio of patients who you initially meet or see, whether it's at the hospital or in the office or you get referred to? What is that ratio of those patients that immediately need dialysis?
Sure. So that's a great question. In our office, I mean, I tell this, a lot of folks, they come in, especially in the office, they just heard, hey, your kidneys are off, come and see us. The first question they have is, am I going to need dialysis? And I would say probably 90+% of the time that's not going to be the case. So most of the folks we see in the office are not going to need dialysis. And it's one of those, part of what we want to do is just seeing them then, and trying to assess what is their risk, what is their likelihood of getting worse. And there's ways we do it just in our head. Of course, it depends, like I said, on a lot of different factors. And I say, we go through the risk factors and all the stuff we've talked about already, looking at the blood pressure, they have issue diabetes, heart disease. But, with good, close monitoring and doing what we got to do, most of the folks, I feel like that is my job, to try and keep you off of dialysis. And there are a couple of folks, yes, they come in, their numbers are advanced, and we know that this is going to be. But even then, our job is to try and slow down that progression as much as we can, with medications, lifestyle, and exercise, and all this. And yes, some folks, and it's one of those things that some folks do slip through. I would say, honestly, I would probably say less than 10% of the folks that I see probably end up going on dialysis. And maybe that's even an overestimate. And the hospital is a little different. The folks we see in the hospital usually are pretty sick. I tell folks kidneys are running along, cleaning the blood, they're working super hard. And they can get concussed really easy. So think about it like a concussion of the kidney when you're in the hospital and you're seeing me. Some folks, they just kidneys just take a hit, they wake back up, they never really shut down, but they just took a hit. But sometimes, they get a big enough of hit, and that's where we end up seeing a lot more patients starting on dialysis, to be honest. A lot of them come directly from the hospital. Okay. But even then, depending on how severe the injury is, like I said, I watch a lot of football, so I use this analogy. There are players, they get a concussion, they sit out for a game or two. But we also know now that, hey, multiple concussions can be troublesome. And if you get one really bad one, then that your kidneys can shut down. And again, they may recover. Those are all things we would be looking out for. But the hospital is a little tougher. That being said, even in the hospital, most of the folks I see on consults don't end up starting dialysis as well. We do everything in our power to try and hold off. Hey, what are supportive measures we can do? Sometimes they just need a lot of fluids. Try and get their blood pressures under, if they're running low, if they're sick, try and get those up, getting whatever infections, bleeding, surgeries, whatever that they had that could have bothered the kidneys in the first place, try to get them back to a better level. Now, there's no magic treatment. And that's the only thing. I wish there was this is what happened. But it is what we call, supportive treatment in the hospital. But going back to the question, yes, in the office, I would say, not that many of our folks. I don't want people being scared when they come and see me, because our job is to try and keep you off that dialysis machine. At the same time, if there is a slow decline in function over time, hey, let's try putting as many roadblocks as we can along the way, start preparing ourselves for an early transplant if you are eligible, as well as what is the safest way to start dialysis, rather than coming into the hospital super sick and then us having to start the dialysis there.
Right. What I wanted to go through next was, I know that individuals find out they're either stage 3, not so much stage 4, but now there's this stage 3A, stage 3B. I know back when I was diagnosed, it was just stage 3.
Right.
So we'll just say stage 3, right?
Yeah.
What goes into, because I've heard some individuals of stage 3 being reversed. How does that happen?
Right.
Like,
so
it goes from 3 to maybe you can possibly go to 2.
Right. So that's great. That's another great, full of good questions today. And to me, the staging, I don't love it. And unless I don't love it, I understand we want to put things label things. We want to put things into buckets because that makes it easier for us to visualize it and think about where we are. But the way staging of kidney disease, whether it's 3A, 3B, or just 3 is what you want to call it, it's really based on this thing called the estimated glomerular filtration rate, the GFR. So whenever you get your blood test, it'll be on there. They actually changed the way they calculated the GFR a couple of years ago. Yes. So that kind of goes along with the whole, it's not the best test, but it's the best one we got. So the GFR is calculated. It's not a direct measurement of everything, but it's a calculation based on your serum or your blood creatinine level. The blood creatinine level, it's a toxin that's in our blood. We all have it. The kidney's job is to filter that plus thousands of other toxins out. So I say that again, this creatinine is how we determine all this, and that goes up and down. So one day your creatinine may be 1.5, another day maybe down a little bit, another day a little bit higher. Depends on when you had a cup of water to drink. It depends on when you take your medications and how much, you may have a little bit of ups and downs, especially with blood pressure medicines. You may see it go up and down a little bit if you depending on what time you do it. I've had patients that get 2 labs in the same day, and the numbers are different, right? And the creatinine is different. So one is 1.3, another times 1.6. So when we're calculating the GFR, so they take your creatinine, the age, the weight, a couple other things that throw into a formula, which is in the lab, we don't do it, and it spits out this number. So you may check your blood work, says, your creatinine is a 1.6, which is a little bit high. So your estimated GFR may be around a 50, something like that. Another day, maybe you drink your fluids, you drink your water beforehand. It's in the middle of the summer, so the numbers are off. Now it's a little cooler outside. You drink some fluid. Now maybe you're creatinine is down to a 1.4, and that's actually closer to a 60. And then that technically puts you from a stage 3 to a stage 2. Now, in my mind, that's good. Obviously, that is better, but it's stable, right? To me, it's a stable, maybe your number's a little bit off, but if we can sustain it there, whether it's the 1.4, 1.6, or whatever it is, that is what I want to see. I always tell folks, you can pat yourself on the back, your numbers are a little bit better, but next time they may not be. I don't think that's a disappointment, but as long as they're staying in that relative range, that's good. One of the nice things, one of the labs we use, they've been printing out little graphs for folks, and when you get the little printout, it's nice. So you can look at it from the last few years and kind of see where things are trending. And they have both the creatinine and the subsequent GFR right below it. So going back to that is, yes, you may see little fluctuations in these numbers. That's going to be normal. I say it is weird if you have the same exact numbers every day, every time. I mean, the numbers are going to be going up and down. Right. Technically, yes, we want those numbers, the creatinine to be less, which means GFR is greater. But going back to the main point is, I don't care what the numbers are as long as they're stable. We got to be looking at your risk factors and what are things that could be affecting the kidneys at every visit I have with you, or if you see any other doctors. So even if the numbers are okay, if your blood pressures are doing okay, do you have diabetes? What else is going on? And I always ask what else has gone on since I saw you 6 months ago, 3 months ago? Did you see any other doctors? Did you see your primary doctor? Did you see your heart doctor? Did anything else going on? Because I want to know any updates. Now, you may say, they just said everything is okay. But for me, that's important because all of that stuff can be affecting these numbers that we're looking at. Because you ask, the best test, there are a couple of things is out there, some technical points. We've always done a creatinine clearance, which is where a 24-hour urine test where we see how well the creatinine is being cleared out in the urine. They compare it to the blood test. It's a little bit of a tougher test to do because you have to save 24 hours worth of urine. You may lose some, or you may do an overcollection. I don't love to do it just because I don't think it changes that much. It's pretty close to where your the creatinine and the GFR would be. Folks at academic centers, they do say, hey, we should be using something called cystatin C. It's a better toxin level that we can check in the blood and the urine. Again, in clinical practice, we can't use it yet, but all that comes to say is all this stuff, it's going to go up and down. We're like putting things into boxes. We like saying stage 3, stage 4, 3A, 3B, in addition to all this. But the reality is these numbers can go up and down. And that's why I say, hey, when you see me, my job is looking at the overall trends. Are things stable? Are they getting worse? Because if they are getting worse, then we got to be proactive in seeing what could be causing them to get worse.
And I'll say this, because I personally experienced your care, and I know firsthand, and this is to anyone listening, that you actually don't put everyone. First of all, you don't put everyone in the box. Your approach is everyone is different, which is what I love. As far as when it's pertaining to my care, that a doctor would. I'm not saying no other doctor doesn't do this, but I'm just saying you personally, I know that you look at a myriad of things. You just don't look at one thing in particular. You look at this, that, is this, is that. And what I wanted to ask, when you talk about the testing, what is the time frame in between the testing?
Sure.
Is it 3 months? And then you okay.
Yeah, it just depends, going back to the individual. Just if there are folks, with a pretty stable stage 3, if you will, I might see them every 4 to 6 months, depending on it. But again, it depends on the risk factors. So, there are folks I see, 6 months. There are folks I see every 3 months. If they're a little bit more advanced, I want to be keeping a closer eye on them. So the other part of this, and just, I don't want to get too technical with it, but in addition to blood tests, we look at urine tests, and we should be looking at urine tests even more.
Why is that important? Tell us why is that important?
So exactly. So the urine's full of all sorts of helpful stuff. But specifically, what I'm looking for is for protein in the urine. When you're leaking protein in the urine, that means there's something wrong with the filters in the kidney. We have a million of these filters. I don't know if you can see, they're nice. They should be nice and tight. Diabetes, blood pressure, everything we talked about before, they can affect those filters and basically cause holes to form in them, if you will. So blood's going on one side. They have all these good protein, blood proteins, as we call them, has not as much to do with the dietary proteins, but these proteins leak out from the blood into the urine where the urine is being formed. It's not clinically, you don't really notice it, and especially at the beginning. But if we detect protein, that just tells me that, hey, the kidneys are more likely to get worse in the future. So, usually we shouldn't have much less than 0.2 grams of protein in the urine. So if when I see you, I say, hey, there's no protein in the urine, that's a good thing. And I say, hey, nothing to worry about. Even there's a little bit here and there, I'll keep an eye out on it. But where we start running into problems is certainly above a gram, 3 grams. I've seen folks 5 grams, 10 grams, even 20 grams. I mean, we're talking multitudes higher, and those are high risk situations. So going back to, hey, what is your, I see a patient in the office. Yeah, they may have mild stage 3 looking numbers. They don't really have, pretty well controlled diabetes. Blood pressure is doing okay, and they don't have protein in the urine. Yeah, I may see them once a year, maybe once every 6 months. And I say, hey, as long as you continue working with your other doctors and everything else, but we will be here as a backup. And I always tell folks, hey, if you get blood tests and things are a little bit off, let us know. We'll get you in sooner, certainly. But yeah, I may say once a year, hey, your numbers are mild, you don't have protein. But on the other hand, if there's someone whose numbers, even if their same numbers aren't bad, sort of mild stage 3, but they have a little protein in the urine or a lot of protein in the urine, we've got to be keeping an eye on that. So I may want to see them every 3 to 6 months, if not even more, depending on what's going on. We may need to initiate some treatment. So yeah, going back to it, it is really individual to the patient, and depending on what's going on with them. Again, their risk factors, their labs, but also their urine test is super important. So, the protein in the urine, that's the main thing that I would say is, a lot of folks, if you have diabetes, you should be getting just routine diabetes checks, A1Cs, as well as normal kidney function. These are normal labs you have done on the basic metabolic panel. They'll keep an eye on the kidney function, but you should also be doing a yearly urine test or something like that. So that urine test that they're doing is probably looking for protein in the urine. And if they do detect protein in the urine, then they usually, most folks will get sent over to us to evaluate and see what we can do about that.
So just to recap on that one question, what stood out to me and what's most important is that your nephrologist should not only be checking blood work, but also urine as well. Those two combined should be tested.
Right. Exactly. And people may have different, how often do we do these things? But yeah, pretty much I would say I love my blood. I love my urine. That's I'm a vampire when it comes to the blood, but certainly I like to have that urine testing done as well. And like I said, it's if things are real stable, we don't need to do it all the time. But usually, if I'm going to see it's a quick urine sample. I just do a spot check personally where, they the lab, they just give you a cup, you go and they sit and they do it. It said technically the best tests are 24-hour urine tests. Again, we talked about that before. It's a real pain for people to do. So usually I just do a spot check to look for protein.
Okay, right. Because urine, well, you mentioned a certain level of protein, but protein in the urine is bad. Am I correct in saying that?
Yes, exactly. We don't want protein in the urine. So exactly right. Protein in the urine is bad. So the levels can vary. It could be, it's not a big deal. We'll keep an eye on it too. We got to do something about this, real soon. So it can be variable. And I've seen big variable levels in that. So, but yeah, in general, we say protein in the urine is bad. Okay,
great. Awesome. I'm gonna ask this question pertaining to individuals who are on dialysis. and then we'll get into some preventative care questions. How can a dialysis patient be successful? When I say successful, I mean have from experience, having good numbers, and also being considered as a good candidate for a kidney transplant.
Sure.
Yeah. How could they be successful in that?
Right. That's another great question. So, in my opinion, I'm always going to say yes to transplant before I say no. And again, I'm not the one that makes those final decisions, but I do refer you. So main factors when I'm referring folks is, I got to educate them and say, hey, transplant is the way to go if we can get that done. It's not like going to Walmart and buying a kidney. It's a long process. I know you've been through it. It's a lot of testing and all that. And there is a surprising number of folks that say, hey, I don't really want to do that. And every time I see them, I'll kind of revisit that. And ultimately, transplant is the gold standard here. There are some, age cutoffs. Again, it's a little bit unique there. I mean, every center has a little bit of a cutoff. Certainly, things like mobility, are you able to walk, take care of yourself, other comorbidities. So if you have severe heart disease and things like that, then those are major issues. But from the dialysis standpoint, I mean, honestly, it's if you come for your treatments, you do, what you have to do. And I know it's a lot, right? So we ask you to watch your fluid and watch your salt and watch this and watch that. But, if you come into your treatments and you're getting them treatments done, even if your numbers aren't perfect, like your phosphorus is a little bit high or this or that, you will still get a kidney because we are working on that together, right? So if we see, hey, we know you're working on phosphorus and your calcium and potassium and all this stuff. But as long as you come to your treatments, we can work on getting your blood pressures controlled and make sure we got you on the right medications, and we know that you're doing your part. I mean, I will always refer you for transplant, and I personally would advocate for any patients like that, saying, hey, they've been coming, and that's the thing. Part of what the transplant centers are looking for is words from us as a clinical nephrologist out in the practice. They will need records from the dialysis center, so yes, they will see any mistreatments. They will see things like that. But even then, we will say, hey, yeah, they missed treatment here and there, but that's because they were out of town. They rescheduled it or whatever. Sometimes numbers don't always make sense. When you look at it, you say, oh, I didn't miss treatments. But yeah, that's what it is. If you work with the doctor at your center, you work with the dietitians and the social workers, like I said, and you are interested in getting that transplant, barring any major other issues going on, like that, you would be a good candidate. And like I said, most of the times we will do our best to push you through.
Yeah. And I try to share with individuals today, even my mentees, that they're looking at a myriad of things. And one of those things is, are you compliant?
Right.
Staying during your treatment time, the entire time, not coming off of the machine or missing any treatments. Those things are very, very important. Not just to get a transplant, but it also keeps you healthy.
Right. And that's the main thing. Like, why do they care about that? And it's like, oh, well, partly, when you get a kidney transplant, as there are a lot of medications and follow-ups and all sorts of things you got to do. And they say, well, are you going to do what you have to do? So when it comes to dialysis, yeah, it's silly. What if I miss treatment here and there? I come off a little bit early, but we're trying to provide the best dialysis treatment, clean the blood, get fluid off, try to keep you as healthy as possible. We know that in general, one missed treatment for you may not be a problem, but we know that increases the risk of hospitalizations, heart attacks, strokes, and pretty much everything bad out there just with one missed treatment. So, and if we know, hey, this is the treatment we need to get the proper cleaning, the proper time, the proper fluid removal, if you're coming off a little bit early, that does, those are red flags for the transplant folks, let alone from us at the dialysis center, because we just want you to get a good treatment. I don't want to keep you there forever. And if you can, I would love to back off. And people are always asking. I say, yeah, I would love to, but and always ask your doctor, hey, why am I on for 4 hours as opposed to 3.5 or 3 hours? Or why am I have to stay longer? Or, but it's always good to ask those questions. I never say, hey, don't ask those. You always ask, why you're doing what you're doing. Why are we doing it 3 times a week versus, these are people. I had this discussion today. I was like, we do dialysis 3 times a week because that's what the government said 50 years ago. And that's what we're still doing. And again, it just works because that way you're able to get those other 4 days off, and then we get shifts and all that. But beyond that, it is we are trying to do the best treatments for you and your long-term health, so then ultimately you can get that kidney transplant in the safest way possible. The worst case, I don't think I've seen it or heard, but I have heard of it. Dialysis patients, they didn't get their treatments done. They get an offer for a kidney transplant. The potassium's 8 or 9 or something like that. So they end up having to do emergent dialysis in the middle of the night. But then by the time the kidney, just kind of ends up delaying the transplant, they end up having to go home because that opportunity kind of, it's not that they don't get a kidney the next time around, but, that time that kind of got delayed. That kidney, kidney's going to be viable for so long. So they ended up going somewhere else because, something like that.
Yeah, you just don't want to jeopardize it. And I commend you, Dr. Kumar, and you get 1,000 brownie points as the doctor stating, hey, ask those questions. Why am I on for 4.5?
Right.
Absolutely. How can I get to 4? How can I get to 3 and 1/4? What? Ask those questions.
Exactly. You should always ask. We're not. Sometimes we'll be rounding. We're just saying, oh, your labs look okay. Everything looks okay. Yeah, it's okay to ask. Hey, I know you said everything was okay. What about my potassium this month? What about this or that? But also, why am I running this long? You see there's all these little fluids and stuff there. If you have any questions, I love talking about that. I know most folks would. So it's always good to ask whatever you want. And like I said, that's your time when doing the rounding.
That's great, man. 1,000 brownie points for you. Stating that, I can't stress it enough. To individuals I come across, you have to ask questions. Even if you don't know what to ask, there are a few questions like, why is a question?
Yeah.
What? How? Those are questions.
Right. Yeah.
Those are questions. So you always have those things available to you. Before we get into a Q&A session, I want to ask about, now I'm not trying to put you out of a job, but I'm trying to get less individuals coming to you as possible, right? And hopefully we see eye to eye there, right?
Absolutely.
So as it relates to CKD, chronic kidney disease, what are some preventative things individuals can do, those individuals who do not have CKD? In your opinion, what's some preventative things?
It starts off this, going back to the basics here, right? So you do little diet, exercise. When I say diet, doesn't even anything fancy, just again trying to stay away from processed foods and fast foods, eating out. Again, once in a while is okay. That's it's going to be the reality for all of us. But what I tell everybody is, hey, the kidney's job is to maintain balance in our body. So how do you help your kidneys out? Is to try to balance what you're putting into your body. So that's the basic way. Go, anyone out there, you go there, you see your doctor once a year, whatever, 30 years old, 60 years old, whatever it may be. You see a regular doctor. They'll do their regular blood screenings, blood tests. They may say, okay, your blood pressure is a little bit high. So work on, doing what they want you to do there. Again, watching your salt and if you need medications. And then, if you have diabetes or what everyone has is pre-diabetes, I put that in quotation marks. I think we're all technically pre-diabetic. We can all become diabetic, as I like to joke about. But these are things. You see your doctor, you look at what's going on with you. And again, just being careful in what you eat and exercise, all the usual stuff. Now, if you do have any of those risk factors that could lead to kidney disease, that does not mean you're going to have kidney disease. That doesn't mean you have to come and see me or any other nephrologist, but be aware, hey, they may, based on the care there, they may want you to come check in with us and just be keeping an eye out, the second set of eyes on your labs, your blood tests, and your urine tests as well. So it's not, like I said, I always tell folks, just because you see me does not mean I'm going to be talking about the big D word and dialysis, right? I mean,
right.
I see that is not the case. So, right. And like I said, now, with all the new stuff out there, if I say, weight control, of course, is important. And they, we talk about these weight loss medications that are out there. Those are things you talk about with your primary doctor. If those are something you need. I also say, hey, remember, kidney's job is to balance. So we want to make sure we're balancing everything that we're putting into our bodies, medications included. And like I said, I personally, I don't think I'll ever be out of a job. I think that we'll always have kidneys. There are always going to be some things that are going on that are not, we don't want them to be. But if we can minimize the stress on the kidneys and kind of slow down the progression of kidney disease, that's the number one thing. So just because we talk about diabetes and all these risk factors, that's what you want to focus on, regardless of where your numbers are. You'll see commercials for all this stuff, Farxiga, Jardiance, Kerendia. There are newer medicines. Again, they don't treat the kidneys, I say, but they can help slow down the progression of kidney disease, specifically when it comes back if you have protein in the urine. So that's why I was saying protein in the urine is important. If you have it, that is a major risk factor. And a lot of those medicines, whether I'm giving it to you or you're taking it for something else, or they say, it's for your kidneys. That's what they're talking about. It's to help slow down the progression of kidney disease. Like I said, a lot of folks, they don't even have to see us. But if you do start having, blood tests a little bit off, urine tests are a little bit off, then, you probably do want to see a nephrologist to best see what's going on and go from there. But yes, most of the folks I see don't need dialysis. Most of the folks that you go to your primary doctor, they have diabetes, blood pressure, probably still don't need to come and see us. But just be aware, hey, I just want to make sure you drink your water. Of course, that's true for all of us. You don't need to go crazy with it, but just make sure you're staying hydrated. And if you notice you're feeling thirsty during the day, probably drink a little bit more. Simple as that. Right. And that's what they always ask me is how much water to drink. There is no right or wrong amount. Just drink when you're thirsty.
Gotcha. I started spreading the word to family and friends. Something you stated early on, how the heart and kidneys are best friends. Yeah. Right. I love that, the way you put that. I'm starting to spread the word that individuals need to start getting their kidneys tested per se, or start paying more attention to look, because it's the silent killer. We know it's the silent killer, right? We don't feel anything. Nothing hurts. Even though there are signs, there are symptoms, there are signs. Not many of us are paying attention to those signs. But I'm starting to share with individuals, hey, when you go to your doctor, I don't care if it's a yearly visit or whatever you're going to do, make sure they do blood work that highlights your kidney function. What do you say to that? Am I on the right track there?
I mean, I would agree. I mean, I think no matter who you are, when as you're getting older, especially, yes, you want to be getting those, whether it's yearly blood tests or every 6 months, or maybe less than that. But that's why I say when you go to see your doctor for your regular checkup, they probably are going to check blood tests, because that's what we do, and that is the best way to screen for kidney disease. You can get blood tests for any number of reasons. You're trying to apply for life insurance, they may do some blood tests there, but the kidney function is a part of that. That just, you don't have to ask for any special testing or anything like that. It is a kidney function test or regular part of your blood test. So they will, undoubtedly, they will be there no matter what. So if no one says anything, you can always ask, hey, what are my kidneys like? They'll probably have them if you've had blood tests in the last year. I'll be honest, most of the toughest cases we see, toughest cases, folks, maybe they're come crashing into the hospital, even in the office. They say, I hadn't seen a doctor in 20, 30 years, hadn't had any blood tests done. And then we catch something that's, pretty advanced. And that's the hardest to deal with. So most folks, because, most folks do have regular blood checks and doctor's visits, that should not happen. And again, like I said, if you have diabetes, heart disease, blood pressure, you're probably going to get blood tests, a little more often. But the kidneys are definitely a big part of what they're checking on.
Awesome. So what I'm going to do is I'm going to allot the viewers to, ask their questions if they have any questions. We covered a lot. I mean,
we did.
we covered a great deal. But I would also, while they're thinking or maybe considering asking a question, I just want to invite you back because
I would love to be back. Yeah, I would love to.
Yes, awesome. That's great because there's some things that detailed things. Mm-hmm. I really want to get into understanding and reading your lab results. Yeah. I really want to get into that and trying to help individuals read those lab results because, and the reason why I want to do this is because I'm really paying homage to your mom. Because she made sure that I understood
absolutely
line by line.
Yeah, and believe me, we still do that. So that's I say if you're still we talked about a lot today actually, and like I said, this is just the tip of the iceberg when it comes down to kidneys and kidney health. So, but yeah, like I said, when I see folks in the office, I expect them, hey, these are your lab results. I want you to know what I'm looking at because it's not for me. This is for you. So, same exact like you said. And we can there's so much we can talk about in the future and hit on bigger points and, new therapies that are out there. We can talk about
definitely.
Less common things that we do run across, but they have new, all sorts of stuff that we can talk about. And people always ask me about the pig kidney transplants and the implantable kidneys and all that stuff. A little ways away, but again, they're definitely things we can always be talking about in the future.
Yeah. We'll put together some slides because we can do that. Sure. And I just think it's needed, the educational piece. And I think individuals, I know for me, and we talked about how each individual is different, but I know for me, I took better care of my health because I understood reading a metabolic panel and what each number meant, and seeing the effects if something dipped or if something just shot up. I understood what those numbers meant. And that's why you probably remember this, seeing me at the dialysis center, and you would make your rounds, come see me, say hello, and we talk about our weekend, and that was it.
Right.
Because I knew I had the numbers on my phone.
Right.
I could speak to even the dietitians. I could speak to, okay, your phosphorus went up, Mr. Merrick. I was like, oh, okay, I know what happened. Over the weekend, I went to brunch.
Right.
And I had 2 blueberry pancakes, and I really wanted them. Right. So let's take the test again in about 2 weeks. It'll come back down.
I have that same discussion still. So with everybody that I see.
That's good.
Yeah. And I said, and I always say, hey, we're not there to scold anybody. We're all human. And it's just about, like, if there is a change, what could have happened? Is there something concerning? If you say, yeah, I know what I ate, that's actually better than, yeah, I have no idea why it went up. And well,
right. Right.
Then we may have a problem. I don't know. So
right. Either one or two things, you're not paying attention as a patient, or something really happened that we got to get to the bottom of it.
Right.
Because, your job, you're saying from your perspective, I'm here for your care. I'm here for your care. And I really want to know what happened, because last month you were great. You were doing great. So what was the issue? So I'm glad you mentioned that. And that as patients, even though I understand from a patient perspective that, I'm dealing with a lot mentally. I really don't want to be here.
Right.
That's number one. I really don't want to be here. I'm tired. And so as a patient, we can't always take it as, like you said, a scolding, or I'm drilling you. No, I have a genuine concern about your health and what took a turn. As usual.
Yeah, that's the thing. You mentioned that, and I, it's always hard for us because we don't see that side of it. I mean, we're not going through what you're going, but the mental things that we have to go through, and both on dialysis, even non-dialysis, as we're preparing for that. I think that's a whole topic in itself, to be honest, that we can talk about. But so, like I said, in the end, we are there just to try and keep things going. That's what we're there for, trying to make sure we're doing our part, you're doing your part. And it's no matter where we are, it's, hey, can we keep your kidneys from getting worse? If you're on dialysis, what can we do to make your life better? And once you have a kidney transplant, if that's the case, how do we keep that kidney going? And that's
that's the main that part.
So, exactly right. So it's a never-ending circle, to be honest. I mean, it's a saga, if you will. So. But yeah, it was a pleasure to be here today. Like I said, we'll definitely look forward to doing this again.
Yes, sir. Yes, we will do it. 2025. We got a whole schedule.
Yeah, it's wild that 2025 is around the corner. So we'll be happy to coordinate.
It is. Dr. Kumar, thank you so much, man. I really appreciate you. We appreciate you here.
Thank you. It's been a pleasure. Like I said, it's been an honor to be here, and we'll continue to working together here.
Yes. And for those individuals who are watching and viewing, you can reach Dr. Kumar at this website. You can always leave him a message there. He's at Southern Crescent Nephrology in Stockbridge, Georgia. And we're just south of the airport here in Stockbridge, not too far from the city. But we definitely appreciate him and his time coming on. And we look forward to seeing you soon back on the Kidney Korner, Doc. And for right now, I am going to put you backstage. Just hang out for just a second while I close out the show.
Absolutely. Thank you. Appreciate it.
All right. Wow. I thought I knew some things, but he definitely put some things into perspective, and I can't wait to be back on the Kidney Korner again. I will put up the website one more time. If you missed that, you can visit that website. If you have questions for Dr. Kumar, you can go to that website where it says contact us. You can contact them, send them a message, or you can email us at getinposition21@gmail.com. I hope everyone learned something. You can also watch the replay of this on our YouTube channel, getinposition21.org. Shoot us a message. Leave us a comment. Let us know if this was helpful to you. Share the link once it's reposted. So listen, as always, make sure you get in position as it relates to your health. This is your host, Craig, with the Kidney Korner Podcast. Until next time, look out for those alerts and notifications. We're thinking about having another one before the holiday period. We're not sure yet. We got a lot of things down, but just stay tuned and follow us. Guys, take care. Peace.